Thank you so much for the honor of being here, Torsten. It's really, I think everyone knows in this room that this is really the birthplace of the objective measurement, evidence-based look at outcomes for bariatric surgery. So it is fitting that this is the place that champions the cause for the younger generation now, the generation that a few decades ago did not have morbid obesity or severe obesity to worry about. So it really truly is an honor for me to be here and to make just a few brief remarks this morning to get things started about really the U.S. perspective on severe obesity in this age group. Just in the way of full disclosure, Ethicon has been very helpful to our investigator-initiated research in long-term outcomes, and the NIH, our federal funding institution, has been also very helpful to us in looking at our outcomes. The scope of the problem in the U.S. certainly begins by a recognition that about a third of our pediatric age group is currently obese, as overweight, as measured by the 85th percentile of their BMI for age. Another 16 to 19%, depending on how you read the data, are actually obese, and that cut point is the 95th percentile of BMI. And the trend there in the U.S. seems to be a slowing, a plateauing of that 95th percentile. But buried within this 95th percentile, of course, are a lot of other groups that are heavier than the 95th percentile. And it's really the most severely affected, what's arguably been termed the 99th percentile, or perhaps more in vogue now is 120% of the 95th percentile. I know it's difficult to fathom, and that there are experts that really argue about where these cut points should be made for definitions. But suffice it to say that this group that is the most severely affected, however we describe them, do bear the greatest burden of comorbidities due to their obesity, and seem to be distinguishing themselves, that is the heaviest of the heavy, distinguishing themselves by increasing in prevalence, even more greatly than those with just obesity. And this slide here talks about another facet of the problem. This slide talks about this severity of obesity and increasing prevalence of severe obesity in the very young, 2 to 5-year-olds. We're seeing, and this is not unique to the US, of course, but it is certainly a problem that is increasingly seen throughout the world. Is there a pointer, Torsten? What you see here is the 95th to 97th percentile. So you see this 95th percentile broken out into 3 groups, the 95th to 97th, the 97th to the 99th, and then the black the black is this 99th percentile, greater than the 99th percentile. And again, this is the group that seems to have the greatest rise from 0.4 to 2.2% over the decades. However, it's not the 2 to 5-year-olds that worry us the most, it's the older kids, the 6 to 11-year-olds, for instance. This 99th percentile, again, having the steepest angle of progression, 2% to essentially 5%. And then, of course, the teenagers. The teenagers reaching a prominence of 6.3% in this one study. And these data are already a decade old, 2003. But it's our observation from work on the ground that this problem, this increasing prevalence in this most severely affected, is only worsening over the past decade. So I mentioned that it is not the scale that's the problem. It's not the fact that the scale is showing us higher and higher numbers, but rather it's the problem of the metabolic effects, the health effects, the psychological effects that this increased weight are adding to the human skeleton. What you see here is really an inventory of some of the problems that are seen with health and welfare in the severely affected. And the numbers that I've put there are very difficult to come by because these numbers represent a glimpse at the magnitude of the problem in the severely obese. So when you look at our data from the experience of the Teen Labs Consortium, for instance, that we'll talk about a little bit more later in the afternoon, but it's really over 200 kids, teenagers, that we have phenotyped very well in this longitudinal study. And we've detected that depression is seen, for instance, in 14%, impaired quality of life in 85%, sleep apnea in over half. We're detecting evidence of renal injury in 1 in 5 of the kids. And of course, they don't even know that they have renal injury, nor do their parents or their doctors. We see fatty liver disease in almost 50%. We see cardiovascular problems, including dyslipidemia in 3/4, hypertension in about half, left ventricular hypertrophy in more than 90% of them, evidence of chronic inflammation in 3/4, endocrine problems in many of them, including type 2 diabetes, polycystic ovary syndrome, and we see stress urinary incontinence. We see things that, again, are seldom measured per se, but have a great bearing on quality of life, have a great bearing on self-concept, and are really, I think, reasons why we need to do a number of things for them, including consider bariatric surgery. One of the things that is seldom seen as well is what is the natural history of pediatric severe obesity. We don't know from the literature what happens to severely obese kids or teenagers, many years down the road, 10 years or 20 years down the road. But if we did know that, it might influence the way we think about taking care of them. It might influence the aggressiveness of our approaches. We sought to get at this natural history question. We have sought to get at this natural history question in a number of ways. This is one that we've recently completed, which is a look at a handful, really only 29 teenagers who were morbidly obese in their teenage years, mostly female, Caucasian, about 50% African American, and with an age range of 11 to 19 and an average age of 15. Their baseline BMI, again, 51, which is quite rare, even for the US standards. But following them up for 7 years, we were able to get a bit of a perspective. What this slide represents is just for me to remind myself that contacting them and locating them after 7 or 8 years was really quite the challenge. But we were able to do so with modern electronic tracking means that were all approved by the ethics committee, of course. And we offered them home visits or to come back to clinic, and we offered them money to come back and do this because they were on with their lives. They really were not being seen at the Children's Hospital anymore, most of them. But what we saw was this. What we saw was an increase in the BMI on average by 6%. And hidden, of course, in average lines and standard deviation bars is a lot of heterogeneity always. But we really did see residual severe obesity in all of them. So it is, I think, a very bad problem to have. And as many other data would support, the problem seldom fixes itself. The problem seldom goes away, and more commonly, I would say, worsens over time. So that is what their weight did, but I started my remarks by saying that it's really the metabolic impact that frightens me the most. And this was their prevalence of diabetes in this group at baseline, 10%. And at follow-up, we detected that none of those initial cases of diabetes had resolved over time, and that another 14% had been added. So that now almost a quarter of them met the definition for diabetes. So again, this is not just maintenance of that exaggerately high BMI and adding to it, it's also adding disease that will certainly shorten the lifespan and will shorten the quality lifespan with an effect on the retina, an effect on the cardiovascular system, an effect on the microvasculature in the extremities, and an effect on the renal system. I've been impressed with our medical colleagues in the US who did a very large study. The consortium that's funded by the NIH is called the Today Consortium. And they have shown us a few glimpses into what happens in the type 2 diabetics in particular. And one thing that should come to no surprise to the endocrinologists in the room is that they have charted weight gain in the diabetics, despite the fact that you would consider a diabetic person has to be followed carefully, treated carefully, and has to be counseled carefully. But nonetheless, in this study of 600 and some adolescents with diabetes, you see, despite which treatment arm, and you see the treatment arms here, despite which treatment arm they got, they all gained BMI essentially over the course of 5 years. What you also see when you look at their response to treatment is the frightening aspect of the development of diabetes in a teenager versus an adult. And now this is maybe an unfair comparison to some extent. This is not a true comparative study by putting slides up that show bars from an adult cohort published in the ADOPT study in 2006 and the adolescent cohort from the Today study published in 2012. But the meaningfulness of this slide is that to some extent their methodology could be compared. And this is looking at the failure of the simplest form of therapy, the oral therapy for type 2 diabetes, the failure rates at 1, 2, and 5 years. And what you see is a distinction between adults and teens, wherein at 1 year, adults were doing quite well with metformin, with only maybe 3% failing that therapy and having to move to insulin. Whereas at 1 year, almost a fifth or a little more than a fifth of the teenagers had failed metformin treatment. At 2 years, the discrepancy is still apparent. At 5 years, half of the teens had failed and only 20% of adults. So what this is being seen as and discussed as perhaps diabetes, type 2 diabetes, that is maybe somewhat more virulent in teenagers than adults. And the same group has pointed out to us that through very, very good studies published in very good journals, that high blood pressure and microalbuminuria as evidence of end organ damage to the kidney increase dramatically over time. And this period of time that they're looking at really is just several years, irrespective of the treatment. And that high blood pressure, for instance, advances or progresses despite good glycemic control. So taking glycemic control out of the equation, high blood pressure still worsens. Dyslipidemia, despite treatment, increased, more than doubled over the 3-year period of observation as well, as published in another paper. So when they looked also metabolically at the beta cell, using commonly employed clinical measures, looking, for instance, at beta cell health with a glucose challenge and deriving this disposition index. In summary, what they found was that they could, through either the hemoglobin A1Cs or disposition index, they could predict at the baseline which patients were going to fail sooner than other patients. And so I think that this idea of a virulent metabolic problem that's affecting the beta cells and will certainly go on to affect the individual patients over time, we have to take very seriously. And we have to take it very seriously in light of what we are seeing emerge from the bariatric surgery literature in the adults. I think that there are a number of conferences that need to be held between diabetologists and surgeons to really sort out how we begin to more systematically offer techniques that work. In a wrap up here then, it's not just what's happening to the teenagers or happening in pediatric ages, but pediatric severe obesity certainly does have a long-term health impact later on. And the studies that have characterized this are few and far between, but for instance, the Israelis that have mandatory conscription do get a very good look at their teenagers and are able to follow them long term. And they're telling us things that are really quite frightening, and that is that adolescent obesity does indeed have an impact on the risk of development of diabetes, if not in adolescence, later on. Coronary heart disease, a 5-fold increase in risk there for having been an obese adolescent. End-stage renal disease and a 3.5-fold increase. And then even the more physical limitations, like walking limitations, are seen in increased risk because of adolescent obesity. So in conclusion, pediatric severe obesity does seem to be increasing more rapidly than pediatric obesity. Comorbidities are developing earlier in life, and some of these conditions, for instance, type 2 diabetes, may well be more virulent in their pediatric form than the adult form. So I think we should look at them perhaps differently. The long-term consequences of the conservative management of pediatric obesity, and particularly when it comes to severe obesity, are indeed quite concerning from the U.S. perspective. And so I'm glad to be here, and I'm very interested to see the rest of the international perspective on the problem.